All right, so welcome everybody to our ACCP Ambulatory Care PRN webinar in which we have three wonderful speakers who will be providing updates in CKD therapeutics. Just wanted to provide a few announcements before we get started with the webinar. First off, we ask that our audience members please hold any questions until the end of the webinar, in which we will have a Q&A session for our speakers to answer any questions that come up. You may feel free to at any time enter any questions that you have in the chat, in which we will keep an eye on them and bring them up at the end of the webinar. Also a note that this webinar is being recorded and will be released at a later time for those who are unable to attend the full time or who are unable to attend. And a handout of the slides presented will also be given at that time as well. And so with that, I would like to present our speakers for today. We have three wonderful speakers who have expertise in the CKD realm. First, we have Dr. Rebecca Maxson, who is an associate clinical professor in the pharmacy practice department with the Auburn University Harrison College of Pharmacy. Her practice site is in a nurse practitioner-led chronic kidney disease clinic. And at this clinic, she has joint visits with the nurse practitioners, and they see individuals with all levels of CKD prior to needing kidney replacement therapy. We also have Dr. Shellie Fravel, who is a clinical associate professor and assistant head of the Applied Clinical Sciences Division at the University of Iowa College of Pharmacy. Her primary teaching roles are in the applications of pharmacy practice course series and the renal integrated pharmacotherapy course. And she additionally serves as a clinical pharmacy specialist in anticoagulation case management service and within the nephrology department at the University of Iowa Hospitals and Clinics. And last but not least, we have Dr. Lavinia Salama, who is a clinical assistant professor of pharmacy practice at the University of Wyoming. Her clinical practice site is set at the University of Wyoming Family Medicine Residency in Cheyenne, and her clinical interests span cardiometabolic syndrome, tobacco cessation, women's health, geriatrics, team-based care, patient education, and improving access to care for underserved populations. So with that, I would now like to hand this off to our speakers for today.
All right, thank you so much, Yvette. I'm going to start us off. So none of us have anything to disclose. And so just to give you a roadmap of how we're going to go today, we're going to start with talking about what is this advancing kidney health through optimal medication management that you saw on the first slide. And then I will talk about the Raceless eGFR equation. And then Dr. Fravel will talk about optimizing blood pressure goals and how to treat those in individuals with chronic kidney disease. And then Dr. Salama is going to talk to us about all the exciting new therapies that we have for slowing progression of chronic kidney disease. So our goal, so I'm the assistant director of the ACCOM is how we call it, because advancing kidney health through optimal medication management is sort of a mouthful. The director is Wendy St. Peter, who is at the University of Minnesota. And our goal is to help all nephrology practices, value-based kidney care companies improve outcomes with their patients by implementing comprehensive medication management delivered by a pharmacist. And so we have been working hard towards these goals. You can go ahead, Dr. Salama. And one thing that we have out currently are some CKD specific continuing education modules. So we currently have 13 modules that talk about slowing progression of chronic kidney disease and the new GFR equations. And then there's 5 more modules that should be released later this month on helping with disparities with Black persons with CKD. And then we have 2 courses in the planning stages that should come out in the next few years. And then our most exciting thing is we're working on implementing a learning and action collaborative. And so this is implementation science. So this is where we take that education and we take that pharmacist and we put them in the nephrology practice. And so you can access this QR code when everything is sent out after our talk today, but it'll take you to our website or to our CE offerings. And then also please follow us on our social media feed so that you can stay up to date with what we are doing. So today we're going to follow this patient throughout all of our sessions. She's a 53-year-old Black woman. She has, like many of our patients, type 2 diabetes, hypertension, chronic kidney disease, hypothyroidism, depression, and she is morbidly obese. For my portion today, the most important pieces are her height and weight. So she's about 5 feet tall, weighs about 265 pounds, and her serum creatinine today is 2. So let's talk about the Raceless eGFR equation. And I want to give a thanks to Wendy St. Peter. She let me use her slides as a basis for my slides, so I did not have to start from scratch. And that was very kind of her. So just to give us a little history. So I was thinking about this today, 1976, our country was 200 years old. My brother Daniel was born, and Doctors Cockcroft and Galt published their equation for estimating creatinine clearance. They based this equation on 249 white men. At that point, the serum creatinine labs were not standardized. That happened in 2005. And so the serum creatinine values today are about 12% lower than they were in 1976. And since this work was done in 1976, we are unable to retrofit Cockcroft-Galt for the new standardized serum creatinine. You move forward to 1991, we have our first estimate of glomerular filtration rate. This equation is a little more diverse. They included Black individuals and women, but everybody has CKD. So this equation is inaccurate at a GFR above 60. And also this is where the race factor is introduced. Then in 2009, the largest cohort equation was developed, and it was the CKD epi equation. It has an estimate of GFR for all ranges, including above 60. And again, we have a race factor. In this equation, it's 1.21. So we move forward to 2012, and the CKD epi collaboration developed an equation that used Cystatin C and an equation that used Cystatin C and serum creatinine. All the previous equations only used serum creatinine. And again, the 2012 CKD epi also includes a race factor. And then with things that we have learned today in 2021, the task force convened by NKF and ASN published their non-race-based equation. This equation is derived from the original CKD epi study participants. There is not a race factor. And if we'll go back just a little bit, I just want to point out that the nomenclature for the CKD epi equations can be confusing, but the subscript is what marker the equation uses, and then the year is, of course, the year the equation was developed. So now we'll move forward. And just the point of this slide is that the CKD epi equations are complex. No one wants to calculate those by hand. And so the National Kidney Foundation has a calculator online that you can use, and you can put in serum creatinine or cystatin C, or if you have both, and it'll give you the number that you need. And you never have to do that complicated math. All right, so let's talk about cystatin C. I'm not going to talk about serum creatinine because we're all very familiar with serum creatinine and its pros and cons. Cystatin C is also an endogenous substance that's produced by all nucleated cells. It is only filtered. So unlike serum creatinine, there's no secretion, just filtration. Just like serum creatinine, there's some non-GFR impacts that affect the cystatin C value, and that includes obesity, smoking, an inflammatory state, which can include being on high-dose steroid therapy, and then if you have hypo or hyperthyroid. And then, of course, the drawback right now of cystatin C is primarily that most labs do not have the ability to run this. It costs a lot more than serum creatinine, and it's not on the auto analyzers. So now let's talk about why take out the race coefficient. So there was, on the left hand of the slide, there are some reasons for why we included a race factor in the previous equations. The problems that we have today with including those factors is that this imbalance in serum creatinine that they saw between white individuals and Black individuals is really based on ancestry, not race. So it's based on how much African ancestry any individual might have. And so we're systematically overestimating measured GFR in Black individuals. Then we have the issue of, do you use self-identified Black or practitioner-identified Black person? From 2010 to 2020 census, there was an increase of about 276% in the number of individuals who identify as multiracial. What do you do there? And then there's implications for health equity. By overestimating the GFR, we are delaying referrals to transplant for Black individuals. We are delaying some of the benefits that they get when you reach CKD stage 4. And so it's a small piece of the health inequities that we see in chronic kidney disease. So in talking about these equations, I mean, is this new equation really useful? That's really the question that we all have. Is this the equation we should be using? So you look at accuracy and bias. So accuracy is the P30 number. So you want the red box. So that's all the people whose eGFR is within 30% of their measured GFR. You want that to be about 90% of individuals. I'm going to go backwards. I'm sorry. I have lost the Zoom screen, so I can no longer. Oh, I'm back. Sorry, that was very confusing. And then bias is actually the difference for any individual between their measured GFR and estimated GFR. And so a small bias is +5 to -5. Now we can move forward. Sorry about that. And then the take-home point from this slide, you can really peruse those numbers if you wish later, is that all the equations have a small bias, but the best accuracy and lowest bias in the equations is when you use both serum creatinine and cystatin C in the CKD epi 2021 equation. So yes, it is the best equation for us to use today. Now the question is, should we use an indexed value or a non-indexed value? So Cockcroft-Gault gives us a non-indexed value in milliliters per minute, and then we're all very well aware of the weight issue. What weight should you use to get that non-indexed value? All of the estimated GFR equations give you an indexed value, mils per minute per 1.73 meters squared. Currently in the US, the average body surface area is 2, which is higher than 1.73. Also, kidney clearance of drugs is proportional to the measured GFR, which is in mils per minute, not that indexed value. So if we use the indexed value to dose drugs, we can underdose patients who are overweight, and we overdose patients who are underweight, which is why the latest FDA guidance document recommends that we use a non-indexed value for drug dosing decisions. So let's talk about YE some more. You can notice with Cockcroft-Gault, depending on which weight you use, her estimated creatinine clearance goes from 24 to 62, which is a very large range. If you notice in the CKD epi 2021 equation, you get different values, indexed versus non-indexed. But notice that all of her values are fairly close depending on serum creatinine, cystatin C. So let's just talk about metformin and the issues we have with dosing. So with Cockcroft-Gault, depending on her weight, she either can't take it, she takes a reduced dose, or she's okay to take whatever dose. And then if you move to the CKD epi equation, just hit the next button, Lavinia, there we go. Indexed value, so that's the mils per minute per 1.73 meters squared, you should discontinue her metformin. If you use the non-indexed value, she can stay on metformin at the reduced dose of 500 milligrams twice a day. So personally in my clinic, I am now doing the non-indexed 2021 CKD epi equation. Most of the time, all I have is serum creatinine, so I use that version. So just bringing it home, when should we use these different equations? So the Raceless CKD epi creatinine 2021 equation can be used for most decisions. Again, we want to do non-indexed. You're going to choose this equation if you can't draw a cystatin C, or if there are many non-GFR impacts on cystatin C. When should you use the combined equation? We are using it in my clinic when the CKD epi creatinine results are close to cutoff points for drugs, like 30 for metformin, 20 for the SGLT2 inhibitors. Again, we're going to use the non-indexed value. And another time you would use this is if we get to the point that the cystatin C level is easily available and inexpensive. When should we do just the cystatin C equation? If there's a lot of non-GFR impacts on serum creatinine, and again, it's non-indexed. And I'm going to pass it off to Dr. Fravel.
Hello. All right. So we will go ahead and shift focus a little bit. We're going to talk about blood pressure now. So this is bringing you back to the case and a little bit of extra information here that I'll highlight before we kind of move on to our questions here. And so let's look at the medications first and kind of hone in on blood pressure medication. So this person is on a 4-drug regimen currently. So amlodipine, a calcium channel blocker, carvedilol, a beta blocker, chlorthalidone, a thiazide, diuretic, and then losartan, an ARB. And so in labs, I'm going to point out a few there too, and you'll kind of keep these in the back of your mind as we kind of discuss some of these points. So the patient has potassium that is currently normal, but kind of getting to the higher end of the normal range, a slightly low CO2 value. The GFR I've kind of just set, we're at 25 for that. And then the albumin to creatinine ratio is very high, so above 6,000, indicating proteinuria is present. In terms of the blood pressure itself, the patient is at 134/77, and then a pulse of 59. Okay, so the question I will kind of focus on in my time with you here is what should be done for blood pressure medication optimization? So the first place we'll start here is just to talk about blood pressure goals. So we have the KDIGO guidelines. That's kind of our go-to set of guidelines when we're making treatment recommendations for patients with chronic kidney disease. And the blood pressure guideline from KDIGO was updated somewhat recently in 2021. And then, of course, we have our AHA kind of standard blood pressure guidelines that were last updated in 2017. And there's a little bit of variance in what the two organizations recommend in terms of blood pressure goals. So we'll start with the KDIGO guidelines. And so there is a recommendation from KDIGO that we should target a systolic blood pressure of less than 120, which is a bit more aggressive than what the AHA guidelines recommend, which is a systolic blood pressure of less than 130. And so in terms of why is there this discrepancy? So I want to spend just a couple of minutes of kind of talking through that. So both recommendations take into consideration one of the most recent kind of cornerstone randomized controlled trials that looked at this question, the SPRINT trial. So this was a randomized controlled trial that looked at kind of aggressively targeting a less than 120 systolic goal versus a less aggressive goal. And in this trial, there was demonstrated benefit in terms of kind of end outcomes in terms of, the patients that were aggressively controlled. The other key thing about SPRINT is that it included almost 30% of patients with chronic kidney disease. And so for KDIGO, from KDIGO's perspective, this is really good evidence. And a lot of times we don't have the randomized controlled trial evidence that we want in this population because oftentimes patients with CKD are excluded from trials. And so on the basis of kind of the evidence from this trial, KDIGO felt strongly that we had good evidence that we should be targeting a systolic blood pressure of less than 120. So the big difference, so AHA also, was published after the SPRINT trial and of course had access to this evidence as well. But it really comes down to the method of blood pressure measurement. So in randomized controlled trials like SPRINT, the way that blood pressure was measured in the trial was according to a standardized office measure. So that means that it took time. So patients came in, they rested for 5 minutes, and a series of 3 blood pressure measurements were taken, and then the mean was used. And that's how patients were treated to that standardized blood pressure goal. Acknowledging that that's maybe not how practice usually is in kind of the real world, AHA felt that that could potentially put patients at harm. And so if you're getting a more routine blood pressure measurement where maybe things are a bit higher because you haven't taken the time to kind of rest and have that series of blood pressure readings, that we could be too aggressively controlling patients. And so that's kind of where the discrepancy lies. So I think it's interesting if you kind of read through the KDIGO rationale, they kind of acknowledge that there is this concern for overtreatment, but it's stated that patients should not be penalized for poor clinic approaches in terms of blood pressure measurement. So I think it brings up a good point. So I think it kind of is a reminder maybe to us as pharmacists that if we are in a position to advocate for clinic processes that allow us to get a standardized blood pressure, of course, that is the best case. But I think in practice, we also have to acknowledge that might not always be the case. And so there are times where we may get a blood pressure and have to kind of interpret beyond that. So that's where the discrepancy lies here. The other thing that I'll note, just a couple more minutes on this slide, KDIGO does acknowledge that certainly we might target less aggressive goals for certain patients, so those with limited life expectancy or those who have issues with orthostatic hypotension. And then the last piece that is unique here, this last bullet I have under KDIGO guidelines, is that they withheld providing a recommendation for a diastolic blood pressure goal. And so the reason cited for that is that patients with CKD often have a wide pulse pressure. And so they felt that it would be extremely rare that someone would have a systolic less than 120 and yet have a diastolic that was elevated, because if anything, it would be even further apart and even maybe a lower diastolic value. And the final piece of evidence, or kind of the final justification that they said, is just there simply is no evidence in the CKD population to assign a diastolic blood pressure goal. So what do you do in practice? I think in those rare instances where you have a patient with isolated diastolic hypertension who has CKD, you'll have to kind of individualize your plan and kind of go beyond guidelines to come up with a plan for that particular patient. Next slide, thank you. So then moving on, so beyond goal, the next thing that we'll talk about here is what agents we should use. And I think this will come as no surprise to most of you listening, and is that for patients with chronic kidney disease, we are focused on use of renin-angiotensin system inhibitors. So primarily ACEs and ARBs are what we are targeting or prioritizing in our therapies. This is especially important for patients that have proteinuria, moderate to severely increased albuminuria. And I've added this table here just as a reminder. So if we're looking at that severely increased box here, so greater than 300 milligrams per gram is that cutoff. And if you recall, our patient today that we're talking about is above 6,000 milligrams per gram. So I think that's kind of unquestionable. I think we all kind of know that that's not new. I think what happens in practice, though, is that we find ourselves in situations where it's difficult to maintain RAS inhibitor therapy in patients with chronic kidney disease. And sometimes we feel that it may be in their best interest to discontinue or decrease the dose. And so we'll kind of talk through some of the recent studies that have asked some of these questions. So probably the most common instance of this is when we have patients with CKD who have hyperkalemia. And we feel that maybe it would be in the patient's best interest to discontinue the ACE or ARB, or at least lower the dose. And there was a recent trial in 2022 that looked at this question. And so in this retrospective study, they were asking the question in patients with CKD and hyperkalemia on RAS inhibitor therapy, what happens if we discontinue versus continue therapy? And they did find worse outcomes when the RAS inhibitor was discontinued in these patients. And I think another note that I will add is that they also found worse outcomes even when the dose was reduced. The next kind of situation that comes up where we, again, sometimes find ourselves questioning whether or not we should push or kind of keep at it with RAS inhibitor agents in patients with CKD is late stage CKD. So people with very low GFR, so stage 4 and stage 5, so less than a GFR less than 30. And so it's kind of this, it's been this belief maybe that it's, well, you know, they've kind of progressed pretty far anyway, and maybe if we stop the ACE or ARB at this point, we can get a little rebound effect and the GFR, and that could maybe delay the onset of dialysis or the need for transplant. And so this was looked at in a recent trial called the Stop ACI trial. And so in this particular study, patients with stage 4 CKD were enrolled, and they did just this. You know, it's a randomized controlled trial where they either discontinued the RAS or continued it. And they actually found no benefit in terms of GFR improvement when they stopped the RAS inhibitor in these patients with late stage CKD. So can go ahead and move to the next slide here. I think what those two studies kind of tell us is maybe what we already knew, is that it is really important to do the work that needs to be done to safely maintain these agents for patients that have chronic kidney disease. So in this slide, I'll kind of highlight some of the tips for doing that. So what are tips for kind of optimal use of RAS inhibitor therapy in patients with CKD? So the first thing, and I kind of already alluded to this in the trial that I just outlined, and then in multiple trials, really, we have this evidence that this is kind of a dose-related effect. So we see better outcomes when we really push the dose of the ACE or ARB to max value. And then the next bullet here, I'm going to spend a little bit more time kind of talking through, because again, I think this is the challenge most commonly faced. So what do we do when we have patients with CKD that have hyperkalemia and they are on a RAS inhibitor and we don't know what to do? And so I think the take home, and we'll get back to our case and kind of talk about this more specifically, but we need to think of other options first. So before we go to the discontinuation or the dose decrease of the ACE and ARB, we need to think about all options for, you know, addressing hyperkalemia. And some of those aren't really, I think, well known or thought about very often. And so there's kind of three things that I think about with patients with CKD. And the first one is correction of metabolic acidosis. So this is a complication that we see somewhat commonly in patients with CKD, and it can cause worsening of hyperkalemia. And so by addressing that or correcting metabolic acidosis, that can sometimes allow us to maintain RAS inhibitor therapy by reducing the serum potassium levels. The next thing that sometimes I think about is whether or not a patient needs to have beta blocker therapy. And so for multiple kind of proposed mechanisms, beta blockers do result in a modest increase in serum potassium levels. And so if we don't have a compelling indication for a beta blocker and the patient doesn't necessarily need that agent to get their blood pressure to goal, we might trade off by eliminating a beta blocker and then maximizing our RAS inhibitor. And then the last thing that is maybe a little bit of a newer approach that we can turn to is the use of potassium binder therapy. So we have two new therapies. So Veltassa and Lokelma are two potassium binders that are used and kind of designed for use for this exact purpose. And so we use them so that we can kind of keep these RAS inhibitor therapies on board and at maximum therapy for long term. So those are some of the ways that pharmacists, I think, kind of step into care and do all that we can, or kind of rule out everything before we have to, maybe as a last resort, discontinue or reduce the dose of a RAS inhibitor. The last three bullets here, I think, are things that you likely have heard, but just reiterate kind of what you know. And the third bullet here is that you need to have confidence when you start or increase a RAS inhibitor, that it's okay. We're going to see that bump in creatinine, and that's okay. So we have to kind of stick with our guns and feel that we know that we're going to see, up to a 30% increase in creatinine, and that's okay. Beyond that, of course, we're going to need to take some action, but we need to kind of stick to our guns and stick with the therapy if we see a minimal increase in creatinine. The next one here, so we know that it's not okay to combine ACEs and ARBs. That's going to lead to both hyperkalemia and acute kidney injury, so that should always be avoided. And then the last thing is monitoring. And so again, I'll just kind of reiterate, I think the role of pharmacy here is that sometimes it's difficult to maintain RAS inhibitor therapy in patients with CKD because they're prone to develop these complications, hyperkalemia. And so pushing through it, reminding everyone of the benefits that we'll see long-term, and then just keeping up with the monitoring. So we need to check blood pressure. Of course, after 2 to 4 weeks, we need to get our eyes on the creatinine and the potassium and kind of keep up with the patient and make sure that we're making adjustments as needed. Okay, so back to the patient. If you can go ahead and click to the next slide if you could. So I'm just going to highlight some of the particular things that we might think about for our patient case here that I've kind of overviewed already. So going back to the medication regimen, so we've got this 4-drug regimen. We don't quite have our ARB maximized, so we have some potential there. We have a lot of protein in the urine and we don't have a maximized ARB. So our top priority really is to get that losartan dose up to 100 milligrams a day. So what are some ways that we can do that? Well, we could just do that and make no other adjustments. However, I think all of us feel a little bit worried when we have that potassium sitting at 4.8. And so maybe proactively, we can take some steps to prevent hyperkalemia that may develop as a result of that dose increase. So the first one, like I talked about, is this identification that this patient does actually have metabolic acidosis that could be corrected. And how do we correct that? We can consider supplementing with sodium bicarbonate. So that's one thing to consider. The next thing that I talked about is going to the beta blockers. So do we need the beta blockers? So if you recall, the patient did not have a past medical history of heart failure, atrial fibrillation. So there's nothing obvious that suggests that we need to maintain the beta blocker therapy. And so if we feel that we can achieve our blood pressure target without the beta blocker, that can be another thing that might help us in our efforts to prevent hyperkalemia as well. So I might say before we move on to the next slide that I never feel super great about, kind of discontinuing a blood pressure medication until we've reached target. So I may not want to stop the beta blocker today. We want to augment the overall blood pressure lowering since we're not at target yet. So that might be something that we do down the line. So before we kind of wrap up with this patient, there's one other question I think that's lingering that you might be asked, or maybe in the back of your minds, you're asking yourself this too, but there's this belief that once we reach these lower GFR levels of around 25, that thiazides need to go. So we have this belief that thiazides are just completely ineffective once we reach this lower GFR level. So the question that we're going to ask now is, should we continue the chlorthalidone, or is it kind of useless at this point? And so luckily, we have this newer trial that looked at this exact question. So this is the CLICK trial that looked at the efficacy of chlorthalidone in patients with stage 4 CKD in terms of blood pressure lowering. And so this was a randomized controlled trial. Half the group was randomized to chlorthalidone, half to placebo. They followed these patients for 12 weeks and found really unquestionably that chlorthalidone was very effective in blood pressure lowering in patients with late stage CKD. And so in the chlorthalidone group, the blood pressure was reduced by a mean of 11 millimeters of mercury compared to just 0.5 in the placebo group. So it was a difference of 10.5 millimeters of mercury. And so really kind of put an end to that question. Of course, you know, there were safety outcomes, and so it's not that it's terribly simple to use these agents in patients with CKD. We see AKI, we see hypokalemia, and so of course this needs to be done with monitoring, but we really have kind of, I think, squashed that maybe myth that we had that there was no efficacy with the use of a thiazide in a patient with late stage CKD. All right, so in the last slide here, I think we'll just kind of, I'm going to summarize and conclude some of the ways that we might choose to modify therapy, or kind of the next steps for this patient based on blood pressure management. So the first thing I kind of talked about is, since the patient does have metabolic acidosis that could be controlled, we could add and supplement with sodium bicarbonate. And then we could also increase the losartan to 100 milligrams a day, maximizing the RAS inhibitor therapy. We can feel confident that it's okay to continue the chlorthalidone at the current dose. We can feel, again, confident that it is contributing significantly to helping us achieve our blood pressure target in this patient, despite the fact that they're at stage 4 CKD. In terms of next steps, I would then implement the monitoring that we talked about. So after making these changes, it would be important to check the blood pressure, potassium, and creatinine, and then also the CO2 in 2 weeks, since we've added the sodium bicarbonate therapy. And then, like I alluded to, if we kind of have achieved our goal, so the blood pressure goal of either less than 130 or less than 120 if it's a standardized measure, and the potassium remains kind of borderline high, that's the point at which maybe we would consider just getting rid of that low dose beta blocker that it seems we don't have any other kind of compelling indication for. And with that, I will go ahead and pass it on to Lavinia.
Hey, all right. Well, my part is a little bit too long, but we'll move through the slides, and some of the information that I have in here are more for reference, but we'll talk about SGLT2 inhibitors and mineralocorticoid receptor antagonists in chronic kidney disease. Mostly we'll be talking about finerenone with relation to MRA. And I really love this slide because it really shows that cardiorenal metabolic syndromes are interconnected, and we often, all of our patients with chronic kidney disease often have diabetes because it is a leading cause of chronic kidney disease. And what we see is, for many years, we've seen that hemodynamic dysregulation that happens within chronic kidney disease. We've been targeting that with ACEs or ARBs. And now more and more agents like SGLT2 inhibitors are also coming into play for not just glycemic control, but for renal protection and slowing down the progression, which is opposite from in the past when they were contraindicated below an eGFR of like 45. And then finally, we target the inflammation and fibrosis with the mineralocorticoid receptor antagonist, being finerenone being the one that is studied and has primary outcomes in patients with specifically chronic kidney disease. And I really love this figure from the KDIGO guidelines that talks about comprehensive care. And I love the words that they are using now, which is called goal-directed therapy, which is similar to how we think, or the language we use when we're talking about patients who have heart failure. So now we're kind of shifting towards, we have more therapies now, in addition to lifestyle changes, in addition to RAS. And now we'll start off with talking about the SGLT2 inhibitors. And SGLT2 inhibitors have many proposed mechanisms, including a little bit of a weight loss, blood pressure reduction because of their natriuresis effects, shifting fuel mechanisms to ketones, and inhibiting that sodium hydrogen exchange. The one that I wanted to focus on today, which kind of plays a role with all of these other mechanisms, is the tubular glomerular feedback restoration that happens. So normally what we see is that as we increase glucose filtration in the glomerulus, we upregulate our sodium or glucose sodium reabsorption through the SGLT2 inhibitor or SGLT2 channels. And that leads to decreased delivery of glucose to the distal nephron in the macula densa, which ultimately leads to downregulation of tubular glomerular feedback and leading to afferent vasodilation, which increases the interglomerular pressure and leads to CKD progression. But I did that on purpose. What SGLT2 inhibitors are going to do is that they are blocking the SGLT2 receptors and leading to more sodium delivery to the macula densa and ultimately constricting the afferent arterioles and decreasing the interglomerular pressure. And they have been shown to decrease chronic kidney disease as primary outcomes. They also have been shown to decrease chronic kidney disease progression in other trials, but as secondary outcomes. So the ones that we'll mostly focus on today are the Credence trials, the DAPA, CKD, and the newest one being the MPEG kidney trial. So starting off with the Credence trial, it was a double-blind, randomized, multi-centered intention to treat trial that randomized patients to either receiving canagliflozin or placebo, and they followed patients every 3 weeks to every 26 weeks by the end of the trial at 12-week intervals. And in this trial specifically, they only included patients who have type 2 diabetes, as opposed to the other trials that we'll talk about shortly. And patients had an average A1C of 8 that we'll talk about, that between 6.5 or 12% is where they met the criteria for inclusion. And they had pretty significant chronic kidney disease, the eGFR between 30 to less than 90, and a urinary albumin to creatinine ratio of 300 to 5,000. And patients had to be receiving the standards of care for chronic kidney disease, which is ACEs or ARBs, which we'll see in all the other trials as well, and they also had to be on birth controls. Because of the risk of ketoacidosis, they excluded patients with type 1 diabetes, and other causes of chronic kidney disease other than diabetic chronic kidney disease were not included in the trial. And I'm not going to read all of this off, but the primary outcome will be our main focus for the presentation. So their primary outcome, they looked at composite end-stage kidney disease, and that was defined as dialysis for at least 30 days, kidney transplantation or eGFR that falls below 15, and it was sustained for 30 days. We also looked at doubling of serum creatinine from baseline and death from renal or cardiovascular causes. And I have the case here to remind you, so that table that is in blue is really highlighting our patient case and how it relates to some of these baseline characteristics. And you see that it sorts of matches. So A1C average in the trial was 8, which matches our patient. Our patient does have significant proteinuria though, 6,000, whereas in this trial specifically, mean urinary albumin to creatinine ratio was 923. But again, our patient was not yet maximized on ACEs or ARBs, whereas patients in this trial, they were. And majority of patients in the trial fell into an eGFR that's at least 60 to less than 90, compared to our patient who is as low of an eGFR as 25. And again, very few patients were in that nephrotic range compared to our patient in our case presentation. But what the trial found is overall, canagliflozin used in patients with pretty significant chronic kidney disease led to prevention of that progression to end-stage renal disease, to dialysis, and death from renal causes. And the number needed to treat in that trial was 22, so that was pretty great. And that was also statistically significant when we're comparing them to placebo. And when we take out cardiovascular death alone from the primary outcome and we just focus on renal outcomes, we again see that this study was statistically significant in preventing chronic kidney disease progression. And these are saying the similar things, which the primary outcome was derived mostly through prevention of doubling of serum creatinine and prevention to progressing to end-stage renal disease. And we see this, that canagliflozin prevented or slowed or decreased urinary albumin to creatinine ratio pretty significantly by 6 months, and then it kind of stabilized. And that was seen in patients with baseline urinary albumin to creatinine ratio greater than 1,000 or less than 1,000 too. And these were just secondary outcomes for reference, but for safety, the one that people we counsel patients most about is the risk for dehydration and the previous black box warning being amputation. And we see that it wasn't really statistically significant between placebo and canagliflozin. And same thing with fracture risks. And acute kidney injury, although was higher in the canagliflozin group, it was not statistically significant. And so all of these studies actually stopped early, and because of their evidence in preventing chronic kidney disease. And this was the very first trial that actually led to a change in the package insert. So like I said previously, Invokana was contraindicated below an eGFR of 45, and this was the first shift to show that it can be used up to an eGFR of 30. And that was the very first change to the ADA guideline, also shifting that these are now compelling, not a contraindication to use in chronic kidney disease. And now moving on to DAPA-CKD trial. So it was designed in a very similar manner to the canagliflozin or the Credence trial, included, but with the exception is that they included patients at a lower eGFR cut points compared to Credence. So they actually enrolled patients with as low as 25. And they also included patients who did not have type 2 diabetes, so they had other causes of chronic kidney disease. And their primary outcome was very similar to that of Credence trial. And we look at our patient compared to the DAPA-CKD trial. Obviously, our patient did have chronic kidney disease, but the urinary albumin to creatinine ratio in this trial was a little bit higher in terms of its mean. But again, our patient is not maximized on ACEs or ARBs yet. Average or majority of patients fell into an eGFR between 30 to less than 45. And again, in this trial, number needed to treat being very significant or positive in that it was 19, and that dapagliflozin did meet its primary outcomes. And these are just the divisions of the overall primary outcomes in that trial in patients with chronic kidney disease and type 2 diabetes. And we see that overall, through the whole picture, is that dapagliflozin is better. And these are just for reference because the slides will be shared. And then the renal outcomes divided, again, very statistically significant. And these were some of the secondary outcomes in the DAPA trial. And then again, amputations, because that's what used to worry patients the most, is that even though it was even lower in this trial, it was not statistically significant. And really one of the ones that was statistically significant was the volume depletion. It was higher in the dapagliflozin group, but again, we counsel our patients to always maintain hydration. And surprisingly, patients actually did not have a lot of UTIs in that trial too. And similar conclusion, this trial was also stopped early, like the canagliflozin group, is that regardless of the underlying etiology of kidney disease, dapagliflozin did meet its primary outcomes. And then moving on to MPA, which is the newest one, and it had a little bit of more addition or more touches compared to the DAPA-CKD. It was very similar. It was similar, but they actually did include a little bit of patients with type 1 diabetes in the trial, which was interesting, but they also had the biggest population of patients who did not have diabetic kidney disease. So if you see, they include patients with glomerular diseases, ischemic and hypertensive, primary causes of renal disease, which was the first biggest trial to do that. And they included patients with either an eGFR of as low as 20 to less than 45, or had an eGFR of at least 45, but had to have pretty significant proteinuria, so stage A2 or higher of 200 milligrams per gram. And the participants, yeah, again, I wanted to highlight that type 1 was pretty interesting in that trial. It made up a very small population, but it was still there because of that risk of diabetic ketoacidosis that we worry about on these patients. Majority of patients fell into an eGFR of 30 to 45, but they did have patients who were less than 30, and that was one of the highest percentages that we enroll patients who are in that eGFR cutoff, similar to our patient case. And majority of patients had pretty significant albuminuria, greater than 300. And we see again here, similar results to DAPA and Credence, is that empagliflozin statistically significant, reduced the number or reduced the prevention of chronic kidney disease in terms of the first occurrence of kidney disease or death from any cardiovascular causes. And these are just a summary of the primary and secondary outcomes, which were all met. And then similar things is in terms of side effects, pretty similar to placebo. None of them were statistically significant. For example, even though dehydration was higher in the empagliflozin group, it was still not statistically significant. And also patients in the placebo group did have dehydration. Ketoacidosis was higher in the empagliflozin group, and I could not find in the supplementary if that 6 patients who developed ketoacidosis had type 1 diabetes, or were they also patients with type 2 diabetes. And this trial, again, like the other two, was stopped early for efficacy. And this is just a summary of all the trials. So we see that DAPA and empagliflozin are the ones that majority of their patients were in that stage G3B cutoff, but they did have people that dipped into that G4 recommendation or G4 staging. And this is a summary because you'll have access to the slides. And this is also a summary from the KDIGO guidelines on the doses and the 3 agents that were studied. So in terms of changes to clinical practice, we see that KDIGO now started incorporating SGLT2 inhibitors as first line, even with as low of an eGFR as 20. And these are the doses that we would recommend. And the things to watch out for, specifically in our patients who are, for example, still on sulfonylurea or history of severe hypoglycemia, because even though the risk is rare, we still want to be counseling our patients on that. Specifically, we want to counsel them on the risk of volume depletion and to maintain well hydration. And this is the new ADA guideline, again, highlighting the SGLT2 inhibitors are first line and they can be used in eGFR as low as 20 based on the MPEG kidney trial. And that's also mirrored in the AACE guidelines. So moving on to one of the last trials, which is the finerenone trial to follow goal-directed medical therapy in patients with type 2 diabetes and albuminuria, even though they are on maximally tolerated ACEs or ARBs and on SGLT2 inhibitors per the KDIGO guidelines. And so MRAs is aldosterone is what we're talking about, the role of aldosterone it plays in chronic kidney disease. And I wanted to point out this aldosterone phenomena, which is, it's 2 distinct phenomena that quite frankly mean the exact opposite of each other. But the one that we'll be focusing on is the inability of ACEs or ARBs to reliably suppress the aldosterone release, for example, in our patients with heart failure and diabetes, which often coexist. And that's also known as aldosterone breakthrough or refractory hyperaldosteronism. And we will be talking about what the harms of aldosterone is in a later slide. But the reason I point out that the aldosteronism and the refractory aldosteronism is because we often don't screen for primary causes of aldosteronism unless patients are on multiple antihypertensive and still have uncontrolled blood pressure for the most part. But what they found in this cross-sectional study, and when they did the oral sodium suppression test in patients, is that the prevalence of primary aldosteronism is actually quite high in the community, including in patients who are normotensive. And we did see the harmful effects of hyperaldosteronism since 1943 from Hansley, who injected salt and deoxycorticosterone, which is a similar molecule to aldosterone, to mice, and they found out that they developed malignant nephrosclerosis, malignant hypertension, and progressed in terms of their inflammation and fibrosis. And if we look at the kidneys alone, the aldosterone is going to help retain sodium and water and increase that urinary albumin to creatinine ratio. But we know that these disease states, cardiac, heart failure, are often interconnected, and aldosterone or mineralocorticoid receptor antagonists are first line in the heart failure guidelines. And if we look at this meta-analysis really quick, I just wanted to point out that when they did a meta-analysis in the addition of mineralocorticoid receptor antagonists to maximally tolerated ACEs and ARBs, they found that although you do get a little bit of a decline in kidney function, which is expected as we decrease the intraglomerular pressure and hyperfiltration, we do see significant reduction in terms of proteinuria, but at the expense of, unfortunately, hyperkalemia. So we know all these beneficial effects of mineralocorticoid receptor antagonists being cardiovascular mortality decreasing, heart failure hospitalization, but the biggest risk remains of hyperkalemia. And this is where finerenone really shines and comes into play. So it's been in the making for years now, and it was shown in preclinical studies that it does have lower risk of hyperkalemia compared to eplerenone and spironolactone, but and it helps reduce urinary albumin to creatinine ratio. The only study that we'll be talking about today is the phase 3 study, is the Fidelio trial. And how we differentiate between the three agents is that spironolactone, which is the one that is the oldest known mineralocorticoid receptor antagonist, and it has the highest risk of hyperkalemia, is because it also has inactive metabolites that can last in the body for up to 24 hours. And these metabolites are active and they can further progress or exacerbate that risk of hyperkalemia. And spironolactone is more selective to the kidneys compared to the heart, whereas eplerenone has a little bit of more selectivity to the kidneys and the heart, about 3-fold. And then finerenone has equal selectivity between kidneys and heart. And that's part of the other reason why it has a lower risk of hyperkalemia. And it also has a relatively short half-life compared to all the other agents. So it's thought that it's a quick on for the benefits and then quick off, so it's not leaving residual hyperkalemic effects afterwards. And these are all the agents, spironolactone, eplerenone, and finerenone, side to side with their eGFR or creatinine clearance cutoff. And finerenone is one that can be used for as low an eGFR as 25 as well. And so the hypothesis that came from the phase 3 trials, the Fidelio and the Figaro trial, which we'll only be talking about the Fidelio trial, is can finerenone slow down the progression of kidney disease while causing less hyperkalemia? And the interesting part about the trials is that the Fidelio and the Figaro trial were actually designed in a very, very similar manner. The only thing that was flipped is the primary outcome for Fidelio was the secondary for Figaro, and vice versa. And then the Fidelity trial kind of pulled all the results from the two large clinical phase 3 trials into one published paper. And so looking at the Fidelio trial, it was a phase 3, a double-blind placebo-controlled trial, enrolled patients in either receiving finerenone or placebo, and then they followed patients just like the SGLT2 trials at 1 month, and then month 4, and then every 4 months thereafter. They included patients who only had type 2 diabetes and chronic kidney disease, defined as either an eGFR of at least 25 to less than 75, with albumin to creatinine ratio of 300 to less than or equal to 5,000. So that's the greatest, highest urinary albumin to creatinine ratio we've seen so far. And then, or patients with an eGFR of at least 25 to less than 60, with urinary albumin to creatinine ratio on that at least 30 to less than 300, and had diabetic retinopathy. And again, in this trial, patients had to be on maximally tolerated ACEs or ARBs. And when they started running these studies, SGLT2 inhibitors were not yet in that gold standard guideline-directed medical therapy now in the KDIGO guidelines. And so patients did not have to be on SGLT2 inhibitors on this trial. and excluded patients with severely uncontrolled hypertension, because we'll see that finerenone doesn't actually have a big impact on blood pressure control. And the way they decided the dosing on whether patients received the 10 milligram of finerenone or the 20 milligram was based on their eGFR cutoff at baseline, which is if they were less than 60, they got the lower dose, and then they could titrate up after a month as long as their serum potassium is less than or equal to 4.8. And again, some very similar primary outcomes to our SGLT2 inhibitor trials in terms of primary looking at kidney failure or sustained eGFR decrease or death from any renal causes. And these are just some baseline characteristics that I wanted to point out, because what we were looking for in this trial specifically is can finerenone cause less hyperkalemia? And so I wanted to point out that diuretics use, because we know thiazides and loop diuretics can actually lower the potassium level. So are we having kind of a balanced effect through there? And they were pretty equal between finerenone and placebo, the number of patients who were on loops and thiazides. Very low usage of both GLP-1s and SGLT2 inhibitors in that trial. And patients had a pretty controlled A1C for their chronic kidney disease stage, which was 7.7. And majority of patients were in the A3 range in terms of albuminuria, or between an eGFR of 25 to less than 45. And what the study found is that finerenone did prevent the progression of chronic kidney disease, and they did meet their primary outcomes with a number needed to treat of 29. And same thing with the secondary outcome. And I wanted to just show some of the breakthroughs from the trial, in that the primary outcome was mostly driven by prevention of sustained decrease of at least 40% in eGFR, which correlates with doubling of serum creatinine. And their urinary albumin to creatinine ratio was reduced by at least 31%, and that was seen as early as 4 months of therapy, and then it kind of stabilized after that. And in terms of blood pressure and A1C, as expected, finerenone did not actually have any effect on these two parameters. And going back to where our patient was, our patient had an eGFR of 25, and we do see that not pretty significant in that it crosses that line of no difference in terms of patients who had the benefits with finerenone, but with the significant albuminuria are our patients that had the most benefit, which is what we see in patients who are on SGLT2 inhibitors, as well as that the outcomes are mostly driven through the prevention of or less albuminuria or less protein in the urine. And in terms of the hyperkalemia, which is what the study was thought to answer to in their hypothesis, the overall hyperkalemia was 18% with finerenone versus 9% with placebo. But the risk of serious hyperkalemia was low, and it did not lead to as many hospitalizations, and that some patients in the placebo group did also experience hyperkalemia. And so these are just some of the other safety outcomes from the trial. And overall, finerenone did, on top of standards of care in patients with chronic kidney disease, did meet its primary outcomes in terms of slowing down the progression of renal disease on a broad spectrum of patients with CKD. And this is just a summary of the trial. And in terms of their incorporation into the guideline, they are considered targeted therapy, specifically in patients who have high albumin to creatinine ratio, just like our patients. And the 2023 ADA guideline also incorporated them as a grade A recommendation on top of ACEs and ARBs to prevent or slow down CKD progression. And so CKD is moving more into, or using similar verbiage into, heart failure. So are we moving into there? And it's so promising to see more and more therapies being studied for chronic kidney disease. And we now have the triple therapy of ACEs, ARBs, and then SGLT2 inhibitors, and also finerenone. And this is a quick kind of summary of the recommendations. So in patients with or without diabetes, but they have chronic kidney disease, consider the use of SGLT2 inhibitors because they are studied in that patient population. Specifically, dapagliflozin and empagliflozin are studied in patients who do not have diabetes. And we want to make sure that we're looking for contraindications. So patients with recurrent UTIs maybe are not ideal for these agents. Foot ulcers, counseling them on hydration and the risk of amputations. And then the most important thing for us as pharmacists too is the sick day rules. And I always tell patients to pause or hold these medications when they are sick to prevent ketoacidosis from developing and maintain adequate hydration. And then we're watching out for any adverse events that happen throughout therapy and adjusting therapies as needed. Finerenone is not yet studied in patients without diabetes, and that's why I didn't include it in the previous slide. But it could be an ideal option for our heart failure patient, possibly in the future, who are not able to be on guideline-directed therapy because of hypotension, because we saw that finerenone hardly reduces or blood pressure. If anything, systolic blood pressure was reduced by 3 millimeters of mercury. And finally, because I don't want to take up so much of everyone's time, is going back to our case. So you really can argue that with our patient, they can be on either ACEs after we maximize the ACEs or ARBs, they can be on SGLT2 inhibitors or finerenone and or both. I wouldn't start the medications at the same time. Usually I'll probably add Jardiance first and then give it about 3 to 4 weeks and then add on finerenone if needed. And then if you're talking to endocrinologist or primary care provider, I would also argue to, as we are titrating ACEs or ARBs, to add on a GLP-1 agonist because the patient does have obesity or BMI of 51. And even though GLP-1s don't have primary outcomes being prevention of chronic kidney disease, but they will definitely help because of the interrelation or the interconnection between all our cardiometabolic syndromes. And with that, I will say thank you to everyone who joined us today. And here's a quick summary of our presentation. Sorry, went a little bit over, and that was a lot of information. So now I think we'll open it up for questions.
Yes, so thank you to all of our speakers for their webinar presentation for today. So we'll move on and have about 15 minutes for our Q&A session. We did receive some questions already from the audience, so we'll go through that, and then also a little tidbit I think shared from one of our audience members. So for the first question that we have, the question is, can you explain what the quote race factor is? Is it the serum creatinine? I believe this question may be for Dr. Maxson, if I'm not mistaken.
Yes, hi, that's a great question. No, the race factor, it's similar to what we're used to with Cockcroft-Gault with females, like you calculate your equation and then you multiply by 0.85 to reduce the result by 15% for females versus males. So similarly, there was an increase for patients with Black race. So depending on whatever the factor was, I think MDRD was 1.18. So if your patient is Black, which how do you determine what that is? That's one of the issues that we have today, but you would select Black and that would increase their result by 18%. So that's what I mean by that race factor.
All right, thank you so much. We'll move on to our next question. How do you approach management of patients with cardiorenal syndrome who may be potentially hypotensive but volume overloaded?
Yeah, so I can go ahead and take this one. So I do think that's a very difficult clinical situation and often a sign of perhaps just a poor outcome, so poor prognostic outcome. But I think in that situation, you do have to clearly rely on diuretics. And so oftentimes when you're kind of preferencing or kind of taking the volume overload piece as your top priority, you're going to have to focus on use of diuretics and perhaps have to discontinue things like ACE inhibitors, ARBs, beta blockers, etc.
Thank you, Dr. Fravel. Next, for our questions that came up, why only giving losartan once daily? Half-life is around 7 hours plus or minus 2.5 hours. Just wondering.
Yeah, so I'll take that one too. I think that's a fabulous point. That is definitely one of those questions that comes up. You know, it's listed as a once daily drug, or can be taken twice daily as well. And based on kind of the pharmacokinetic data, you could certainly support using it twice daily. So I think if you have a patient who's maybe not meeting blood pressure targets and they would be capable of being adherent with a twice daily losartan dose, that's certainly something that could be considered.
Thank you so much. I think this is just a little tidbit shared by one of our attendees. So one thing we see a lot in practice is SGLT2 being discontinued by PCP, endo, or even nephrologists as eGFR drops below 30. But worth highlighting that these agents can be initiated as long as eGFR meets the labeled thresholds, 30 for Canagla, 25 for DAPA, 20 for EMPA, and can be continued as eGFR declines until transplant. So thank you for sharing that. We'll move on to our next question. Do you think patients would have the same benefits on? Oh,
can I add just a little? That was a great comment. And I think all the trials continued the SGLT2 inhibitor until dialysis started or the patient received a transplant. And there are 2 trials I'm aware of going on right now of using SGLT2 inhibitors in patients on dialysis. So that's a great point that these can be continued.
Thank you so much. All right, and so we have more questions coming in, so please feel free, everybody, to enter in your questions. Next, we have, do you think patients would have the same benefits on our needs with finerenone, so that being our sacubitril valsartan?
Yeah, so I actually haven't seen any studies come across, but I don't see why not they wouldn't. They have 2 distinct mechanisms, and they are both in that heart failure guideline-directed medical therapy. The benefits to finerenone compared to the other 2 agents that we have, other than its studies in chronic kidney disease and all of that, it doesn't lower the blood pressure. And so that might be really a great option for our patients who are hypotensive or are likely may experience hypotension from the Entresto therapy. I don't know if any of the other speakers have anything to add to that.
Okay. Great, lots of great questions coming in. Yeah. Next, we have, if a patient has tried or failed SGLT2 once due to ADR, such as hypotension, genital myocardic infection, have you ever successfully reintroduced it? And if so, any tips to doing so?
Yeah, so I have actually had a patient who was adamant that she wants to be on SGLT2 inhibitors. And so she was a perfect one that I could work with in terms of yeast infections and SGLT2 inhibitors reintroduction. So we actually worked on controlling her blood sugars first because she did have diabetes. So below 200 is where I got her. And then we put her on fluconazole, and there are some very low grade studies on prophylactic doses of fluconazole to prevent mycotic infections in patients. And she had one as a standing order in case she gets it. But one of the papers that I was reading is that you can do that fluconazole when they get it, but if they have more or recurrent, then you can start thinking about prophylactic dosings for up to 6 weeks of one-time fluconazole every week. And she was agreed with that. But really the big counseling tip I tell patients is maintain well hydration, and let's get your blood sugar under a little bit of a good control before we up your dose or before we retrial this agent again.
All right, great. Thank you so much. We'll continue moving through the questions and get through as many as possible. And so our next question, are you aware of any studies ongoing to evaluate renal outcomes in MRAs, that is spironolactone, eplerenone? In theory, they should have similar effect as finerenone, just with more risk of side effects.
So I'm not aware of any such studies, but in Lavinia's slides, she did present that not systematic review. I'm sorry, my words are leaving me. But she had a great slide on meta-analysis of what data we do have with the eplerenone and spironolactone.
Yeah, I'm so sorry, my computer cut off, but yes, there are not like studies that have primary outcomes with spironolactone and eplerenone, but that meta-analysis that I shared, there's actually an updated one with it that includes some of the early phases of finerenone. I do have it on the presentation, I just didn't go over it because of time, So yeah, these are the only really studies or meta-analysis that we have on the other agents compared to finerenone.
Great, thank you so much. Moving on, next question. Is there a preferred, quote, preferred ARB for hypertension?
So I'm not aware of any preference, between the ARBs, especially, in a CKD population. I think I've read some kind of provocative, interesting stuff about maybe ACEs versus ARBs. So I feel like that's something that's maybe gaining a little bit more attention and kind of looking at some outcomes that we wouldn't maybe think of being associated with, those different classes. But to this question, I'm not aware of any preferred ARB.
Okay, and next we have, is risk of ketoacidosis on sick days for patients taking SGLT2 regardless of diabetes status? Is there a risk, I believe that's the question is asking?
Yeah, I counsel them whether they have diabetes or not to make sure that they maintain well hydration. And on the sick day rules, I actually have a handout that I made, and sick day rules, whether they have diabetes or not, is to pause it. And I would rather them drink plenty of fluids or the recommended fluids for their status and recover.
Okay, great. Getting down to a few of the last questions. Next would be, why would you be concerned about UTI with SGLT2 inhibitors in a non-diabetic patient? Would you be concerned?
I wouldn't be as concerned, but because it's one of the most commonly known side effects, I still do counsel patients on it, especially if they have a predisposition. But we do get rid of a little bit more sugar even without having diabetes. So it's still a counseling point and a good thing to monitor for with the hydration and the proper hygiene, but I'm not as concerned about it, but I would still talk to them about it for sure.
Great. And then moving on to a few last questions. When starting SGLT2 in someone with CHF or CKD on a diuretic, would you recommend preemptively reducing the diuretic dose to avoid volume depletion as long as baseline fluid status is stable?
For sure, I would. I would always, if they have like really high doses, especially loop diuretics, then I, of course, would ask them to work with their cardiologist. But most of patients with heart failure take additional doses when they are more swollen. So I would get their baseline doses first of their loops and then see which ones we can take off and to monitor their weight and then go based off of there. Because with the loops, you can definitely adjust. But SGLT2 inhibitors, it's just a one set kind of dose. But yes, I would.
Okay, great. And for our last question, what might be the causes of sustained reduction in GFR after initiating SGLT2 as an adherent patient? That is, for example, if GFR continues to drop more than 2 months after initiation.
Yeah, so I kind of use the same approach as ACEs or ARBs. So if it continues to drop, can we reduce the dose? And if reducing the dose doesn't do it, well, assess for other causes first, like Dr. Fravel so beautifully mentioned. So are they like doing significantly more exercises and leading to dehydration? Are they did they start NSAIDs over the counter again? That happens a lot. And then assess if they started other diuretics or anything else that could possibly lead to volume depletion and more progression in terms of the chronic kidney disease. And then I would reduce the dose if possible. If not, then I would hold it and then repeat the kidney function in 2 to 4 weeks, and then see where they are at, and then possibly retrial or like just see how their kidney, if it bounces back significantly after holding SGLT2 inhibitors, then it's a risk benefit discussion. And if it dips back down again, then definitely stop it. And that's the unfortunate kind of like ACEs or ARBs. It's not like you can do a potassium binder now with the other agents, but maybe there'll be something in the future.
Okay, great. Thank you so much. So with that, we have come to time for our webinar presentation for today. So would like to thank all of our attendees for joining, as well as all of our wonderful speakers for sharing their expertise. Just as a reminder, again, this webinar is recorded and handouts will be available. So we will be sending out those at a later time and publishing them onto our PRN YouTube webpage. But if any questions do come up, please feel free to reach out to any of us. And thank you everyone again for your time. And I hope everyone has a wonderful day and a wonderful weekend. Thank you again.